Hi, it's Kristen here at UT Southwestern. Today I'm excited to be joined by Dr. Iyengar, a radiation oncologist with our Department of Radiation Oncology. We're going to be talking about lung cancer and radiation therapy for that. As usual, please don't forget to ask your questions in the comments field. We'll take as many as we can get to. We do want to remind our viewers that we've got to be careful about very specific patient treatment questions. We can't answer those, but we'll definitely speak in generalities and answer as many as we can get to. And we also want to thank our partners before we get started, which is the Moncrief Cancer Institute, Department of Radiation Oncology, and the Simmons Comprehensive Cancer Center. So we're going to go ahead and get started. Thank you for joining us.
It's wonderful to be here.
Should be a great conversation. So to get started, what is radiation and what are some instances where it would be applied?
Sure, and this is one of the most basic questions that we get when a patient comes into our clinic. And the way I really start off talking with my patients is to simply say radiation are x-rays. In the most basic sense, they're x-rays. Everyone has had an x-ray for a broken bone, for some injury. And so these are x-rays that are more powerful, that you can't see or feel, but they come into our body. And the modern day version of radiation oncologists, we shape the radiation to focus and to actually kill the cancer where we aim the beam. Wow. So we use radiation just like a surgeon would use a scalpel to cut a tumor out. We aim the beam, but without scalpels, in a non-invasive way to kill the cancer. And so many patients come in to our clinic for lung cancer treatment and for an opinion on when we use radiation. But I tell my patients that we actually use radiation for all stages of lung cancer. For the earliest stages of lung cancer, if they're not a candidate for surgery, then we will apply a very important technique called SBRT. It's just a fancy way of saying a high dose of radiation that our department here at UT Southwestern has pioneered globally to eradicate early stage lung cancer. We use it for intermediate and locally advanced cancers, meaning cancers that may have gone beyond just where they started and spread to lymph nodes. We use radiation usually in those settings in combination with chemotherapy or immunotherapy or other therapies. And finally, we use radiation in most advanced cancers and stage 4 cancer for two main reasons. One is in palliation to help with pain, control of symptoms, but a more emerging field is to use radiation to help chemotherapy control disease in stage 4 cancers in hopes of improving their survival. So we can use radiation for all stages of lung cancer.
It's fascinating. So we've got a question here. What are the biggest myths about radiation treatment?
The biggest myths about radiation for lung cancer specifically is that it's going to cause some massive injuries to my skin, it's going to cause a burn. I don't like to use that term. I think historically, back decades ago when our technology was not as good as it is now, we were not able to deliver radiation internally without causing damage superficially. Now with the most advanced techniques that UT Southwestern and other institutions employ, we're able to deliver radiation safely and effectively to the tumor without causing significant damage more peripherally or superficially.
I've definitely heard concerns from people about that superficial damage. And so since we don't have to do that, what are the potential benefits of radiation therapy?
So I think the first and foremost benefit of radiation for lung cancer is cure. So for early stage disease, with the approaches that we use, as we talked about, the high dose radiation delivered over very few treatments, pioneered by our leaders of our department, we're able to get a cure. So these patients do not have to worry about lung cancer in the areas we treat, and hopefully those patients are cured. In more advanced patients, we've shown that radiation improves their overall survival, and the time for which they don't have any disease, and it basically delays significantly the time that disease comes back.
So are there any kind of side effects or complications that people would want to be aware of?
I think with the most common complications are in the patients with the stage 3 cancer, locally advanced cancer, and it really is a question of where their disease is located. Okay. So if some of the disease is located in lymph nodes that are near their esophagus, which basically is relevant for feeding, They may get a little bit difficulty swallowing over the course of the radiation, or maybe pain on swallowing. But these symptoms are all temporary, and we get all our patients through. And after a few months, the day by day, the further out they get from the radiation, the quicker they'll recover from those side effects. Again, those are temporary. Otherwise, depending on the extent of disease in the lungs, there may be some inflammation in the lung. We can diagnose that relatively quickly and offer different types of medicines in the form of steroids to suppress that inflammation, to reduce the symptoms associated with the radiation.
Okay, good question. So we have another question in here from Mary, and it's, I think you can address this. Aside from smoking, what are the biggest risks for developing lung cancer?
That's a great question, and it's a very important question because more people die, and historically over the years have died from non-smoking related lung cancers than breast, prostate, and colorectal combined. I'm not diminishing the fatalities in those illnesses, but non-smoking related lung cancer is a very significant problem. And what we hypothesize is that there are a lot of things such as radon gas, which is inhaled from the environment, and that may be perhaps the second most significant contributor to the development of lung cancer. Now, a lot of families that live in houses with basements, I strongly recommend radon gas evaluations, and otherwise, when you're moving into a new place, you should look into that as well.
So is that, how would somebody do that?
I think there are, I think it's just like someone who's going to check to see if your smoke detector is valid.
Okay.
They can do a radon gas evaluation, things like that.
Okay. Really good question. Thanks for asking. So related to that was another one that we had in here that you talked about the risks. What can somebody do? Are there ways to reduce your risk besides not smoking?
Again, to check and make sure about the radon gas, but as of right now, there's really no other firm driver that we know of that is going to increase the likelihood of development of malignancy. So aside from use of tobacco products, there's nothing else that's very obvious to us at this time.
All right, good question. So getting back to the radiation therapy itself, how many treatments are typically involved, and what do those sessions look like? Are they long, short?
Sure. So the earlier the stage of the disease, it tends to indicate the smaller the volume of the disease, okay? And that we've caught it very early before it's developed and spread to the lymph nodes. In those cases, we can get away with treating patients in just 3 sessions, 3 one-hour sessions, and they are done with the curative approach to treating their lung cancer. Usually it's spaced out over a week or a week and a half. With respect to disease that's more advanced, because it has spread to lymph nodes, it's closer to more critical structures, including the esophagus, the spinal cord. We tend to stretch that radiation out over a longer period of time so that each independent dose is safer. And in that sense, those treatments usually last perhaps over 6 weeks. Once a day, again, for about an hour. Mondays through Fridays, weekends are off. And there's another approach that our department has been pursuing over the last decade or so, which is to try to provide as much dose in a fewer number of treatments, not the 3 treatment course that I discussed, but to maybe, instead of doing 30 treatments over 6 weeks, maybe doing 15 treatments over 3 weeks. And we've spearheaded studies that have basically shown that we can safely deliver the amount of radiation that people get in 6 weeks and 3 weeks with similar levels of outcomes. Wow. So hopefully in the near future we'll publish on those findings, but it may be a new paradigm shift in how we at UT Southwestern, and perhaps more nationally and globally, will be able to deliver radiation as effectively in a much shorter period of time.
So are you then doing, it's basically half the time, are you combining the radiation, just giving them a larger dose?
Yeah, we're doing twice the dose every day, basically. And historically, people were worried about the side effects, but we've shown in multiple studies now that there's not any increase in toxicity with doing twice the dose. But again, our group is able to ask these questions and answer these questions because of our history and knowledge and being able to treat patients with higher doses per treatment.
So with those higher I mean, what precautions should patients take, if any?
I don't think there's any extra precautions they should take beyond, the approaches that we talk about in terms of maintaining, adequate breathing, being active. So my patients ask me all the time, how should I behave? How should I act? And I tell my patients to do whatever they've been doing as much as possible. So if they take walks around the neighborhood, if they go to the grocery store, to be as active as possible. I think that's the best approach in terms of recovering from the treatment.
Okay, good to know. So we've got a great question here from RC, and it's two parts. Can you explain the benefits of stereotactic radiation and how it minimizes damage to surrounding tissue and organs?
Sure.
And is this now the standard in treating cancer tumors?
Okay, so stereotactic treatment, which we talked about a little bit before, we called it SBRT. But in general, this high dose treatment that's delivered over a few treatments, the reason we can apply this technology is the fact that nowadays every patient gets imaged before their treatment. So we know exactly where the radiation is going, and that's called image guidance. And because the lesions are small, because they're earlier stage cancers, we can deliver the dose to the small lesion and avoid collateral damage. Because the way we've developed this technology is that there's a quick and rapid fall off of the radiation dose. So it's not sprayed over a very large volume. It's delivered to the tumor with a very small margin to ensure that we don't miss it, but otherwise the fall off of the radiation is very rapid. And the second part of the question is a very important one. Is this now the standard of care? I would argue, and most would argue, that it is the standard of care for patients who are unable to undergo surgery. Our institution is now pushing the envelope here at UT Southwestern to determine whether it should become more standard of care when compared head-to-head with different types of surgery. So in patients who can't have surgery, yes, stereotactic radiation is the standard of care. In patients who can have surgery, whether it's a small surgery called a wedge resection, or what we call a sublobar resection, or a larger surgery where they take out the entire lobe that the tumor's in, we are doing a study that's comparing head-to-head radiation in the form of stereotactic treatment versus surgery to see which treatment will offer a better benefit in terms of survival for the patients. So those studies are ongoing at Southwestern nationally as well as internationally, and they'll be able to tell us if stereotactic treatment is as good as surgery. And that would be a great leap forward for the use of radiation in lung cancer.
Wow, great question. Thanks for asking. So this is a question we have from Brittany, and it's related to what you touched on earlier, but can a person's diet impact their lung cancer risk?
I mean, that's a question that's dear to my heart for multiple reasons. Our laboratory group happens to study how tumors utilize different nutrients in the body to grow, lung cancers and colorectal cancers. But in general, I personally, and I think many others, would not believe that there is a specific diet that would or would not increase your likelihood of developing cancer, or once you've been identified to have cancer, if there's a specific diet that you should partake in that will help you have a better treatment response. We just don't have enough information to say definitively one way or the other.
Gotcha. Okay, good question.
But one more thing I would say is that for patients who are getting significant treatment for their lung cancer, I think personally calories are very important, because calories are what will be necessary to build the building blocks for normal tissue recovery. And so I think whatever you want to eat, I think it's good to eat in order to achieve an improvement in normal tissue recovery.
Perfect answer. Great question. So what about going to, when you're undergoing radiation for lung cancer, how much of the healthy lung will be in the field? Any? A little bit?
I would say, so the area that has the lung cancer is probably no longer really functional. So that functionality has been lost already. What I tell my patients is that there will be some extra area that will get normal tissue that will get radiated. The reason is because in the lung, unlike other areas, tumors move with your breathing. So if we don't account for that motion and deal with that motion, we will either underdose the tumor or overdose normal tissues. So we do account for that in our treatment planning. But in order to make sure that we treat all of the areas that we think are at risk of having cancer, we do treat a little bit extra in order to ensure that possibility.
Okay, so what about this question? Can someone receive radiation in the same area if there is a cancer recurrence or a secondary cancer?
That's a great question. So two things. Usually if a patient has had high doses of radiation previously for an area and the cancer recurrence is in that exact same area, it is often difficult to re-irradiate that area to the fullest dose because of the concerns of the normal tissue side effects, okay? But if the recurrence is in a different area, we certainly can re-irradiate that. And our group, again, has a lot of experience with re-irradiation, because oftentimes we get referrals from patients who have had a previous attempt at curative treatment. Now they have failed or recurred in multiple areas, and they get sent to us to be able to try to add some radiation around the area that was radiated before. So there are certainly many options to try to re-irradiate, but it does make it a little more complicated.
Okay, good to know. So just to remind everybody, we're about a little over halfway through our chat. We have less than 15 minutes left, so now's a great time to submit those last minute questions you have so we can get to them. Here is one that we just got in. Besides chemotherapy drugs, are there other treatment regimens given with radiation therapy?
Yes, there are. And so most people have heard recently about the incredible results with immunotherapy. And very simply put, immunotherapy is a class of drugs for which the Nobel Prize was given this year. It's a class of drugs which help our own immune systems attack our cancers, okay? And there was very significant studies recently done where patients with stage 3 lung cancer got chemotherapy and radiation, and then they went on to receive either immunotherapy or a placebo. And those patients who got the immunotherapy after their chemotherapy and radiation lived significantly longer. And that has now become the standard of care. So it's not just now about radiation and chemotherapy, but it's now radiation, chemotherapy, and immunotherapy in combination, working together to improve the survival of our patients. Now, the next question you may ask is, will immunotherapy one day take the place of chemotherapy?
Exactly.
And those studies are ongoing. And so we will know at some point in the near future whether we don't even need any chemotherapy because the immunotherapy is good enough.
Wow, that sounds amazing. So related somewhat, but is a patient more susceptible to infection with radiation?
I tell my lung cancer patients that I don't expect them to have an increased susceptibility just from the radiation. Now, if they're also getting chemotherapy, the chemotherapy may affect blood counts, and those we watch very closely with our medical oncology colleagues. And so if the counts get too low, they would potentially be at increased risk of infection. But in general, I tell my patients that, try to avoid, family members, patients, other people who are sick. It's just generally a good idea because you're going through so much treatment. But I don't necessarily think that the radiation predisposes patients to increased risk of infection.
Okay, good question, Cece. So here's one that we've got. Now you've mentioned UT Southwestern a lot here and other studies that are underway. What clinical trials are you involved in?
So we're involved in several clinical trials, one of which I'm the national investigator on. And it's the point that I made in the beginning of our talk, which is in every stage of lung cancer, we can use radiation. But historically, radiation was used in a limited fashion in stage 4 patients who have theoretically the worst outcomes in just palliation to help with symptoms. But more and more, we're trying to identify subsets of stage 4 patients who may actually benefit from a local therapy benefit. So I have a trial that is ongoing here at UT Southwestern where we're basically looking at patients who have stage 4 lung cancer with limited volumes of disease, and we're randomizing them to either the continuation of their chemotherapy or immunotherapy, which is a standard of care, or we're adding radiation to see if the addition of radiation will actually help them live longer. So that this is really the future of stage 4 treatment, and we'll see if it pans out. Other studies we're certainly doing here, as we'll be opening up soon, a study where we're looking at immunotherapy in the setting of small cell lung cancer, of which individuals here are national investigators on that study as well. And then we have a number of other studies that we do here at UT Southwestern looking at radiation combinations with chemotherapy and immunotherapy that we work with our medical oncology colleagues.
Awesome. So related to that, what do you see as the future of radiation oncology, particularly as it relates to lung cancer?
Yeah, as I said, I think lung cancer patients of all stages will benefit from radiation. We will see in the next few years whether surgery or whether SBRT or stereotactic radiation is as good as surgery in early stage disease. It may become a de facto standard of care, and it's great for patients. In more advanced disease, we'll see if radiation will work with immunotherapy to improve survival in both stage 3 and stage 4 disease. So I think those are the directions that radiation will be implemented in greater and greater levels.
So why should somebody come to UT Southwestern? What sets UT Southwestern apart from others in lung cancer treatment?
I think we are, for lung cancer treatment and radiation, we are at the forefront of any technological advances that are being implemented that will serve two purposes. One, to control the disease, but two, to also reduce the normal tissue side effects. As I said, we are a mecca for stereotactic treatment. People come from all over the world to Southwestern, to our radiation oncology department, to learn about how we do stereotactic, and then they take it elsewhere. So we run many courses of that ilk. I think that we also think outside of the box. We're not satisfied with small incremental advances. We're looking for changes by leaps and bounds. And in doing so, that's why we're trying to combine all of these high-dose treatments done in shorter periods of time to see if they're more effective in fighting the lung cancer. So I think for all of those reasons, we want to move things massively to improve the lives of our patients significantly, not superficially.
Perfect. All right. So we have a couple more questions. We got about 5 more minutes. You can give me last-minute questions. One of them that came in advance of the chat was a person that wanted to remain anonymous, but asked, can radiation therapy actually cause cancer?
That's an excellent question, and the answer is theoretically yes. And what we tell our patients is there is always a chance that radiation itself is an inducer of tumor development, but if it happens, it would happen 10, 20 years down the line, and certainly I hope for my lung cancer patients that would be a problem that we would have to deal with. But ultimately, the benefits that are provided by radiation would far outweigh the minimal risk of developing a secondary cancer from the radiation. And the other thing I wanted to really say really quickly is that our goal ultimately, I think, as a field is to make lung cancer a chronic illness, like diabetes, like heart disease. It may be that you get the cancer, we treat it, but then a few years later we treat it again, a few years later we treat it again. By making it a chronic illness, we're trying to improve the survival of our patients.
Wow. All right, there you go. So we've got time for 2 more questions, and one of those is, how do I know if radiation therapy is the right treatment route for me?
I think every lung cancer patient needs to be evaluated by a multidisciplinary team like the one we have at UT Southwestern. That means seeing a pulmonologist, a medical oncologist who deals with chemotherapy and immunotherapy, a surgeon, a radiation oncologist. After you see all of us, we put our heads together and provide what we think as a team is the best first treatment for the patient.
Okay. All right. Last question. This is actually one that I had on the bottom of my list. So I was looking at your faculty profile that said you do a lot of research into cachexia, and I was curious, why is that an important focus for you?
Because for me, lung cancer patients, but in general, beyond lung cancer patients, 30 to 50% of all cancer patients develop cachexia. It is a wasting syndrome. You see it in lives of all family members, friends. Towards the middle or end of their disease, they start wasting away. They start losing a lot of weight. They start losing their appetite. And we believe it's because the cancers are causing these conditions. So we know that if we reverse the cachexia, patients would live longer independent of any other treatment they receive. So, and it's mainly an inflammatory driven process, we believe. So we think by understanding how cachexia occurs, how tumors break down fat and muscle to cause wasting syndrome, we can improve not just the quality of life of our patients, but the survival of our patients as well.
citizens. All right. Well, I think that's all the time we have. We're out of time for today. I want to thank everybody for all of the great questions you submitted. As a reminder, this will be here on our Facebook page. You're able to share it and watch it again, and we'll also share it on our YouTube channel this afternoon. So if you have friends that aren't on Facebook that you'd like to see this, please direct them to our YouTube channel. In the meantime, I definitely want to thank Dr. Iyengar for joining us and answering all these great questions.
Happy to do so.
All right, well, tune in next week. We'll have another chat lined up on CT lung cancer screening. And thank you for your time today.